We don't yet have any questions from the audience being flagged up to us. So I'd encourage you all to get thinking and get sending some questions in. Otherwise, Lynn and I have got half an hour to come up with questions ourselves. So please help us out. So the final speaker is an old friend and colleague, Maite Tome. She's a consultant cardiologist, currently at St George's Hospital in London, and she's going to talk to us about managing pregnancies in patients with inherited cardiac conditions. Thank you, Maite.
Thank you very much for inviting me, and it is an honor to talk about the in the journey of life, or the life journey in inherited cardiac conditions, about managing pregnancy in women with ICC. Women with inherited cardiac conditions, as Ellie has told us, will get pregnant, and we need to have in mind that women with cardiac disease in pregnancy are at a higher risk of complications. Heart disease is the leading cause of maternal death in pregnancy in the Western world, with 1% up to 4% of all pregnancies complicated with heart disease. If we take the data from the confidential inquiries into maternal and fetal death in the UK report from last year that looks back into the previous 3 years, 2016, 2018, unfortunately, 217 women died. And the leading cause of those deaths, as you can see, was cardiac disease, with 50 of those women of 217 affected with cardiac disease. This talk, however, is not about death. It's about appropriate risk assessment based on the understanding of the physiological challenge that pregnancy is for inherited cardiac condition women, and also how to best manage them based on the data available with updated guidelines, having a good individualized care. We need to do the homework and understand the hemodynamical and physiological challenges that the pregnancy takes for any women. The marvelous increase on the cardiac output to deliver a healthy growing fetus, it will be done on expenses of phenomenal transformations on the hemodynamical side, with an increase of the blood volume to the 50%. We're going to increase the cardiac output between 30 to 50%, and that will be possible through reduction of the systemic vascular resistance, increasing the heart rate, that the warnings, particularly after the 28 weeks to 32 onwards, which will be the only way to maintain the cardiac output. Pregnancy is a status of hypercoagulability, and our kidneys will filtrate different, the hepatic flow will be different, the lungs will get compressed as the pregnancy advances, and therefore the availability and disponibility of the drugs we're going to use is going to change. Where do we learn more? How do we base the advice we give to our women? We have to base our advice on the information that is available, that is largely improving through registry type data. So we all know the limitations that information is, but I'm glad to say that as per today, we can actually give our decisions on registry that they have 10 years follow-up, about nearly 6,000 pregnancies, and they have been collecting systematic data. This is the case that the guidelines that they were published in 2018, which is based on this data, propose a change on the known risk classification, the World Health Organization, in a modified one. They're going to promote, as the most important messages, pre-pregnancy counseling and the importance of the pregnancy heart team. Why they propose a change? Because you can see that this classification has got higher sensitivity. You can see this is the prediction under the curve. It is much better. So everything is about to follow the rules. So you need to your premorbid status. You need to know what is the condition of someone embarking in pregnancy, and therefore you will be able to assess the likelihood of maternal cardiac event rates, starting from the possibility of no increment on death a very mild associated morbidity to a situation where you will find that M4, where there is prohibited an increase of death or severe morbidity is such that the counseling will be against pregnancy. According to that, you will give counseling to every woman regardless, but you will plan the care and the location of the pregnancy through expert centers, referral co-located hospitals, the frequency of the visit, and the location of the delivery. So what are the perils of the management? The perils of the management is to understand this as a circular part of care. This is not linear care that with an exit after birth. This is, you cannot choose, and ideally you would like to have the time to have preconception counseling every time. But if you are particularly like myself, that I joined the high-risk maternity team at St. George's, you might not have a choice in which part of the circle you might be able to meet your pregnant women. Every lady should be under a multidisciplinary team, whether it is in situ, which is virtually, which is on the phone because you have a network, but any of the needs should be available and you should know how to deliver it. Ideally, if you have the opportunity to see them for preconception, the idea is to do a risk assessment, to review the health style, the lifestyle, to update the family history. Maybe it's time to review the genetic information, review the medication, and discuss options. Your role is to discuss, to put the options to the mother who will make her choice about getting pregnant. Your role will have to explain very clearly what will be the implication of that decision for herself, for her baby, and also where it's likely to have to deliver that baby. And also it's a good time to talk about future contraception and encourage planned pregnancies. We need to know a little bit about what sort of drugs we can use. And the truth is that there wasn't much information available. So now we have more information coming. And everything is governed by the same principle. This is the principle of balance between the needs and the risk. So if the risks are prohibited, we tend not to give them. So this is what we call contraindicated. As such, nothing is contraindicated. It is that the risks are not worth it. Or medication where we might need, but we have to put mitigation plans afterwards, like with beta blockers in the monitoring of the babies, etc. So before ruling out any drug, do your homework, see the up-to-date information, and think that this is a moving part of knowledge. For the benefit of time, I think only we're going to have time to go a little bit through the basics of the care and with examples of hypertrophic cardiomyopathy, peripartum cardiomyopathy, or any decreased ejection fraction situations, and inherited orthopathies. What do we need to know when we are managing any cardiomyopathy? So you need to know your physiology. So what is the cardiac reserve in your patient? How will get by when it needs to increase the cardiac output on expenses of tachycardia, on expenses of vasodilatation? How will tolerate the pregnancy without drugs, with drugs, or with which drugs? And in that sense, you will have a very good idea of what you are doing. It's particularly important to understand that in that modified World Health Organization algorithm, most of the ICC conditions are going to fall in the category from 2 onwards, with a few of them in contraindications. Hypertrophic cardiomyopathy sits, depending when it has got a predictor of complication like obstruction, in 2 or forward. So we're going to see that ejection fraction depends where it sits, more or less, or 40% is associated with higher risk, and the same with the size of the aorta with regard to the complications. So if you're not familiar with these guidelines, are very practical, well written. You need to see that these are the predictors of complications that we will use in terms of the counseling and management of our patients. Hypertrophic cardiomyopathy can present in many ways, as we have been told, And these are patients, all the cases that I will have hopefully time to discuss with you, have patients that have managed through the COVID period because people do not stop getting pregnant and mummies still need care no matter whether we have a pandemic or not. So this is a 29 years old with diagnosis of hypertrophic cardiomyopathy, mild presentation, and no need of medication, dyspnea class 1, with low risk score, who has planned her pregnancy. In contrary, the 20 years old that also have to care at the same time, she came pregnant, having presented 3 months before to hospital with paroxysmal atrial fibrillation, where she was told that she needed to take bisoprolol and rivaroxaban, and that she probably had cardiomyopathy. By the time she came to clinic, the first echocardiogram shows that she had severe hypertrophic cardiomyopathy with outflow tract obstruction, about 80 millimeters of mercury, even though she had a previous pregnancy that, according to her, was completely uneventful, as she has a 5-year-old daughter. So what's the situation here is that most patients with hypertrophic cardiomyopathy in reality are going to tolerate the pregnancy very well, and vaginal delivery will be the safest mode, the safest method in most cases. We, however, had to put a few precautions in terms of the management of blood loss, use of vasodilators, of excess of beta agonists. However, those who had previous arrhythmias, outflow tract obstruction, any heart failure related presentation, or they need an ICD because a higher risk profile, they might do different, it might need very different care. To prevent cardiovascular hyperdynamic status, we might offer all of them beta blockers. However, we need to individualize. So you see the case number 1 was locally supported delivery in a unit. We had a collocated obstetric by cardiology, but it's no high risk maternal unit. She took no medication. She didn't want to through the whole pregnancy. And she had a vaginal with an epidural, and she did very well. And she had a coil postpartum. Mom and baby are doing very well. Case number 2, she had to be anticoagulated throughout pregnancy, plus beta blocked. We knew she likely would go into atrial fibrillation again at some point, so she did. She was ready. It took us to cardiovert her from leaving the house until she presented at the hospital with everyone ready, less than 3 hours. We thought that she might need to deliver at the time. We added disopyramide, and we get her weekly, and we managed to get 4 weeks, which we are very proud of. And in the end, she delivered vaginally. She refused to have any medication because she did it very well first time around. And she has a healthy baby boy that is a normal size. And here and me now are talking about myectomy. Orthopathies are challenging. And what I would like all of you to remember is that while most of them are going to do very well, the prediction that we have about risk are related about risk of dissection, which will have very serious implications for mother and baby. Overall, if you have the diagnosis, overarching diagnosis of orthopathy, you might have to consider about a 3% globally risk of dissection. Luckily, because of the data we manage, if you have an aortic diameter in the proximal aorta less than 40, perhaps that risk is a lot less, and it's less if it's associated with a bicuspid aortic valve. And if it's prohibited, with more than 10% risk of dissection in cases where for example, Marfan with more than 4.5 or even a lower diameters with low STs, and completely prohibited regardless of the diameter in cases like vascular Ehlers-Danlos because of the potential risk of uterine rupture. So we need counseling very early. So we need counseling with any time that in theory, in teenage years, we need to explain how important is to try to, if they want to plan a pregnancy, to do it in early diameters if possible. When we get closer to the matter, we would have liked to discuss with them all the concepts that Ellie discussed with you, as this population, particularly the Marfan one, tend to opt for PGD more readily. We need to discuss about contraindications for pregnancy, or in some cases whether surgery might be an option before. And we need to plan that if we are worried about dissection, the place of delivery is going to be a cardiothoracic center. So this might have implications of where they live, and we might have to move for that. If we could, we would like to counsel people with a full aorta scan, no matter how many echoes you have done, that is not older than 18 months or 2 years, to have an idea what happened with the descending aorta at the time. Vaginal delivery, is it possible? Of course it is. The only thing is that you will find that in the registry, a lot of these patients will end it in C-section, and it depends a lot on the team and the capabilities of monitoring. What it matters is we have a very good strict control of the blood pressure, and we try to avoid vagotonic. So the guidelines says to avoid levometrin, and that we are ready to scan the aorta at any suspicions of a significant change. We need to be a little bit wary of the advice only related to the aortic root diameter, like this case, because her family history includes aortic dissection in the third trimester of one of her aunts. So in her case, she has done very well, but we did actually try tolerance to beta blockers before we embarked for pregnancy. We had done a full aortic scan. We have followed her very closely. And even though everything we did, she actually developed preeclampsia, and she had to be delivered a little bit early. There's a lot to say about DCM peripartum cardiomyopathy, but I thought the message I want to say is that it can be very difficult to know when present acutely in pregnancy, and the most important thing if heart failure presentation happen in pregnancy is to suspect it. To try to make the diagnosis at the time, it might be something that we might relabel with time, and in fact, in that effort, the Heart Failure Association promotes that the diagnosis of peripartum cardiomyopathy, it is reserved for when the ejection fraction is less than 45% and no other identifiable cause of heart failure has been found. So there are many algorithms and many actions for that, but here the most important concept is you need to suspect it, and if there is no healthy mommy, there is no baby. So this is a critical situation where the pregnancy might not continue, and it depends on the viability of the baby. Now everything that has been labeled like peripartum cardiomyopathy is peripartum cardiomyopathy, and we all have experience of that because we don't have the luxury to know whether someone has familial DCM. And this is the case of this large family, which I have many family members under follow-up under my care, where the peripartum cardiomyopathy, it is almost in every family member if you go to 2 or 3 generations up. But we have found that they carry a tight mutation, so maybe it is or it isn't. The truth is, these 3 generations down is doing much better, and this individual would like to know what, how is it going to go for her? Is it going to go like her grandmother, or is it going to be fine? So she has been healthy, well, and she has normal size ventricle, normal ejection fraction, and opposite her counterpart here, which is a little bit older than her. She has had 2 previous pregnancies. However, later on has been diagnosed with probably DCM in the context of arrhythmogenic cardiomyopathy family. By the time she gets pregnant, she has a ejection fraction between 35 to 40%. She has got a very high BMI. She's in the late 30s, she's 39, nearly 40. She has been offered termination by the time she comes to us. However, due to COVID, this early termination is not possible. By the time she elected care, she actually has want to continue for pregnancy. We don't know the outcome of this one just yet. She's hovering safely between 30 to 33%, and we have a whole team assembled for delivery, and we are seeing her weekly. The one with the carry with the tight mutation, the best predictor we told her was the ejection fraction pre-pregnancy. We offered her beta blockers that she declined, monitoring pregnancy, and then a good postpartum assessment. Her pregnancy is so far going very well. I'm nearly done, and I have to say that we need to have as good as pregnancy planning. We need to have a postpartum monitoring, discussion of a contraception, and the implication of getting pregnant for the future cardiovascular risk. And yes, to finish, as a take-home message, what we need to do to care better for patients for managing pregnancy through with ICC is to prepare, to work as a team, to anticipate, to know your physiology, know your drugs, be ready to ask for help. Remember that this is a circle of care that does not end at birth. And thank you very much.
Thanks, Maite, for an excellent talk, and thank all the speakers for what has been an excellent session.